Hello, friends. This is Kerry Morrison. Thank you for joining me today for another Conversation from the Heart. Today, I welcome Dr. Dave Pilon, who was the author of a well-received proposal that was submitted to the state of California last year, outlining a bold approach to payment reform in our mental health system. The proposal envisioned a 5-year pilot in Hollywood that was inspired by the guiding principles of the global best practice of community-based mental health care in Trieste, Italy. But as we shall see from this conversation, these guiding principles show up in various ways in the United States as well. We will explore how a humble place like a clubhouse in Massachusetts or a vocational training program in Los Angeles helped to shape Dave's approach to a system change pilot that revealed remarkable results at the Village in Long Beach in the 1990s. And why is kinship and the pursuit of meaning in life so important to one's recovery path when confronted with a mental illness? Welcome to this discussion. Hi, this is Kerry Morrison, and welcome to Heartforward, Conversations from the Heart. And today I am so delighted to have who has become a very good friend and a colleague in this journey we've been on to look at alternatives to our mental health system, Dr. Dave Pilon. And I really, really wish we were sitting together in a room and then we could go to lunch afterwards, Dave, because would be far more preferable. But in this time of COVID, we are taking advantage of technology to have this conversation, and I'm really excited to see you today.
Back at you, Kerry. I suppose the positive spin on all of this is that if we lived in an era where we didn't have this kind of technology, nothing like this could ever take place. So I guess we should count our blessings.
Exactly. So we will make do. So I didn't get to know you until about 2 years ago. And I know you had a whole lifetime before I entered your life on this project we worked on together. So I just want to roll the tape back a little bit and have you share a little bit about your education, your career. And I'm always interested because this is not my space. How did you decide to go into the field of psychology or social psychology? What was the attraction for you?
I guess I've always been fascinated by people's motivations about what sort of drives them, what makes them behave the way that they do. I'm a vet. I was in the military, and my very first roommate in the military happened to be a psychiatric technician. And he would give me these stories about his work with vets that he was working with. I was about 19 years old at the time, and it just sounded fascinating to me. And so I decided that when I left the military, I wanted to go to college and I wanted to study psychology. I was actually a double major. I also studied English literature because I think that it informs our understanding of human behavior almost as much as psychology does.
Definitely Shakespeare, probably,
yes,
right?
Absolutely, as well as many others. But that was sort of the original interest there. And then I thought I actually wanted to be an academic at first. And so I went to grad school thinking that I would, take an academic path with my career. But I have to admit that 5 years of graduate school convinced me that I didn't want to be in academia.
Where did you go to undergrad and grad school?
So I was an undergraduate at Cal State Long Beach, local boy. I was born and raised in Southern California, born in Inglewood, raised in Torrance, went to high school at Bishop Montgomery High School. I had a Catholic parochial background, both grade school and high school. After my military service, I went to Cal State Long Beach. And when I graduated from there, I was accepted into the Department of Psychology and Social Relations at Harvard University. And there I received my doctorate in social psychology in 1981.
So what a big change from Long Beach to Massachusetts.
Absolutely, in so many ways. To be quite honest about it, I don't feel like I was prepared for the Ivy League experience. That's not to say it wasn't a great experience. It was, but it was culture shock to some extent. But as I said, after 5 years of graduate school, I decided that I needed to find something besides an academic career. And I applied for a job of outreach worker at a clubhouse in Lowell, Massachusetts, about 30 miles north of where I lived in Cambridge.
So let's explain what the clubhouse is in the mental health context.
So at that time, I had no clue about what the clubhouse model was. I was applying for a job as an outreach worker. You have to remember, this is 1981, so it's almost 40 years ago. I showed up for my job interview as an outreach worker at this big Victorian-style house, and I was greeted at the door by a young man, probably about 20, maybe 21, whose name was Scott. And he said, I'm here to, show you the tour of the facility. And I said, great. And we walked around, and you have to understand, And at that point, all of my experience with people with mental illness had been basically on hospital wards, doing internships and seeing people when they were in the throes of their, crisis with their mental illness and that kind of thing. And so he was showing me around, and he showed me people working, people in the midst of doing clerical work and maintenance work and these kinds of things. And everybody was upbeat and positive, and showed me around for about 15 minutes, introduced me to everybody, and then dropped me off at the director's office, whose name was Connie. And Connie's first question to me was, well, what did you think of the place? How would you feel about working here? And I said, this place is so different from most mental health organizations that I've been to. I would love to work here, especially if more of the staff are like Scott. And she paused for a second and she said, well, Scott's not a staff person here. He's a member.
Wow.
What you don't realize at that time, I looked puzzled and I said, what do you mean a member? That word had no meaning for me. And she said, well, you probably refer to him as a patient. And I cannot tell you how mind-blowing that was for me in that moment. It was eye-opening in the sense that idea that this person who obviously knew more about mental illness than I did with my newly minted PhD and knew a lot more about what appeared to be sort of happening with these members. I cannot tell you the impact that had on me in this life in that moment. And I actually had to convince them to give me the job.
So it was very humbling for a Harvard PhD to actually.
It was incredibly humbling. And my whole several first years in the field were filled with those kinds of humbling experiences. But it really made me understand that there was a different model, a different way of treating people than what I had been accustomed to, even in my short series of internships, that you could actually focus on the positive aspects of life, the belonging and the meaning that people were seeking, regardless of whether they had a mental illness or not. And so I had to convince them to give me the job because I thought I was overqualified. but I did get the job. And from that point on, the next 35 years or so were in the field of psychiatric rehabilitation, which is what this field is called. And I feel so blessed that the Clubhouse model was my first experience in the field.
It just seems that it informed so much of your perspective, not only for what we're going to talk about here in a moment at the Village, but also ultimately what we've been trying to do with the Trieste pilot. The Clubhouse is so simple and so profound in how it views its members, how it views people. So what a fortunate occurrence that was, that they gave this highly academic guy this job. That was awesome.
Yep.
So you were in Massachusetts then, working for this Clubhouse for several years. And I know you ended up in Long Beach maybe around the late 80s. How did that transition happen?
Well, I spent the next 3 years at this Clubhouse program in Lowell, Massachusetts. And in 1985, I decided that I wanted to move back to my roots, be closer to my family. So I actually took a job at another psychiatric rehabilitation clubhouse called Portals at that time in central LA, in the Wilshire area of central LA. And I became the director of community integration programs, actually running all of their community integration programs, but particularly their clubhouse program as well. I spent about 2 years there till I decided that, well, I need to get into a situation where I can get my licensing hours. So in 1987, I started working as a psychological assistant to pick up my postdoctorate hours so that I could become a licensed psychologist. And in 1989, I got my license as a psychologist and immediately started looking around for another job back in the psychiatric rehabilitation field.
So I want to just take a pause. Now that I'm fully grasping that you were at Portals in 1985.
Yes.
And on Wilshire, I'm thinking that we probably walked past each other because remember, you and I have talked about Corporate Cookie, which was a vocational program operated by Portals,
That's
right?
Correct.
On Wilshire Boulevard, just east of Vermont. And I used to go there almost every day to pick up a cookie after lunch and a coffee. And I never quite knew what was it about these people working at Corporate Cookie. They were clients of Portals.
That's right. They were members. They were members of Portals program. And the funny thing is when I moved back here in August of 1985, my office mate next door, a man named Paul Berry, had just started working there at Portals the week before with the expressed intention of creating the Corporate Cookie. And so I was there watching as he developed Corporate Cookie, which was, as you point out, a retail business right in the heart of Wilshire across from Bullock's. And your experience, by the way, is very common. It's like everybody everybody would walk into that place and say, man, these are great cookies. But there was a weird vibe about the place.
I know. I just feel like we've come full circle because I really would love to see corporate cookie rise again. That's on our wish list, right?
Yeah, absolutely. But you're right. That was one of, not to jump ahead in the story, but helping people find meaningful employment or vocational roles is one of the key foundational concepts that a functioning mental health system should have. And it's just striking how our mental health system always thinks of that as ancillary rather than as core to people's mental health. Is that first you get the symptoms under control and get people on meds and all of that. And then if they're ever, quote unquote, ready for that, then you can sort of like start thinking about employment. No, it's got to be the opposite. You need to be thinking about those kinds of things from the very beginning. But I'm probably getting ahead of us. Yeah.
Yeah, but you're laying the frame where you're providing a teaser. Yeah. So you need to get your hours to get your license. Tell us a little bit then about your transition to the Village in Long Beach, because that's a super important part of your life story.
Yes. So in 1989, the leadership at Mental Health America of Los Angeles reached out to me because the person who was working at MHA as their development director knew me at Portals, and Julia, MHA was looking for somebody to both run their community integration programs, their psychiatric rehabilitation programs, and they were looking for somebody who could help them to write a proposal promising models. And they came back and they said, from what we've seen out there across the country, we need to have a new model here in California. And they wrote legislation. It was AB 3777, the legislative number. And that established 2 pilot projects and a countywide project in California. So one was supposed to be an urban project, one was supposed to be a rural project, and then there was a countywide project. The county actually was finally chosen for this was Ventura County, and the 2 nonprofits were in Long Beach. We won the proposal in 1989. Up in Stanislaus County in Modesto, another nonprofit won the rural project. And basically what those projects were is the proposal said, tell us what the best way is to fix this system. What would you do? And so MHA hired me. I was the sort of lead writer on that proposal. And there were really 2 fundamental components to that proposal. It's like the clubhouse and what your listeners may have heard of before, what is called the assertive community treatment model, the ACT model, which has had many incarnations between then and now. But that's what it was originally called. It was a model that came out of Madison, Wisconsin, actually in the 1970s. And it requires a lot of outreach and intensive engagement with people with severe mental illness kind of thing. And so we wrote a proposal that merged those 2 primary models, the clubhouse model and the ACT model. And in our program, we called it the Village Integrated Service Agency versus the one that was up in Stanislaus, which was called the Stanislaus Integrated Service Agency. But for 6 years, those 2 models, those 2 programs were studied about the kinds of results that they got using these new models. And it's very unusual in community mental health that you actually ever get a randomized control study. But in that particular case, our members were randomized either to us or into a control group. And so you could actually compare the outcomes of the people in the control group versus the people in the treatment program, which was, in our case, the Village. And so over a 6-year period, we could actually see how are we doing vis-a-vis people who didn't get that treatment.
So you had the opportunity to not only design through the proposal that was accepted by the state to fund as the urban component to the urban rural study. But then you also were involved in designing the actual program that was going to be administered to the control group. And so...
Well, no, the control group actually just got usual and customary services. Sorry.
Got it. Okay.
Sorry. So they were just getting the services in the community that they always got. But what the evaluator did was assembled a pool of 240 people and then randomly assigned 120 of them to the village and randomly assigned 120 of them. You get to keep getting what you're getting, kind of.
To usual and customary services, right? So now the village has a study group of 120 people. And what did you design? What was the village then? What were you testing in this research?
So the basic services that everything else revolves around is this idea of giving somebody a place where they feel like they belong. I mean, fundamentally, nothing else works unless the person says, this is my go-to place where if I'm struggling, if I'm having a difficult time, I know that these people care about me and will stick by me regardless of what's going on in my life, kind of thing. They'll come and visit me when I'm in the hospital. They'll help me. And it's not just focusing on the mental illness. Fundamentally, it's about helping people to get a life. And that has to be the fundamental driving force or motivation of the program. And what does it then mean to get a life? A lot of philosophers have argued about that, obviously. But I'll just use Freud, talked about the importance of love and work. I would broaden that to say belonging and meaning are critical to every person. But if you have a severe mental illness, your belonging and your meaning can get eaten away by your mental illness. It just throws huge challenges in maintaining those things. And so a program has to be designed to help people to overcome those challenges, whatever they are. And everybody's challenges are different. Obviously, it's not going to be the same for every person. But the fundamental thing that people need is what we call service coordination, is that you need to have somebody in your life who, when you're struggling with all the doors that are closing and you can't get people to listen to you, you have a partner who can sort of help you to navigate the system. The other term that people often use, which I'm not crazy about, is case manager. I had a member once tell me, I'm not a case and I don't need to be managed. So I said, well, that's fair. People don't mind the term service coordinator. It's like somebody to help you coordinate the many challenges that our bureaucracies impose on us, kind of thing. So that has to be fundamental. But in addition to that fundamental connection that somebody is there for you with all the challenges you face, the program has to help you focus on finding meaning and belonging. However you define that, it's like the vast majority of people want an intimate relationship in their life. You don't need, if you don't want it, we're not going to force it on you. But if that's something that's important to you, then we will help you to find that. If you want meaning in your life, for most people, that means either paid employment or some sort of volunteer work or something like that. It can be just being a grandparent. It could be being a friend. Those are all meaningful roles, don't get me wrong. But in our culture, employment is probably the primary way that people achieve that. And so we said at the very beginning, we're going to dedicate a huge amount of our resources to helping people find meaning through employment. And that was one of the fundamental aspects of our program.
So it's interesting. This is very new that you're developing. And I think one of the things in some of the documents I've read about what you accomplished there was that there was this notion that people could recover. That recovery was actually a journey people could be on with a mental illness. And that was kind of an anathema to maybe what was the conventional wisdom. And that word, I would just say as a layperson, because I'm not trained in this area, recovery has, I think, a different connotation. Recover means like, oh, I've recovered from the measles. They're gone. They're completely gone. But recovery in a mental health context has a different significance. Can you describe that?
Sure. And, full disclosure, when we started the village, the term recovery had not made its appearance yet. And to be quite honest about it, I thought that people who we were serving in the village would need us their entire life. In those days, I was not a believer that people could recover fully, to be quite honest about it. I had to be convinced through many years and watching people say, thank you for your help. I don't really need you anymore. I'm doing okay. But the term recovery was actually coined by a man named Bill Anthony around 1991 or so. And it quickly became, we adopted that very soon after at the village, probably in 92 or so. And it has become the standard, as you mentioned, that there is a general understanding now that people with severe mental illness can recover and can have full lives out in the community with minimal support from paid staff. Everybody needs the support of friends and family. Don't get me wrong about that, but it's much better to get that support from people who aren't paid to provide it. But that's not to say that there isn't a role for service programs, especially because because many people with severe mental illness have become estranged from their families for whatever reason. And so it is incumbent on our system to step in and fill that gap to some extent and provide them with the support that they need. But yes, you're absolutely right. Recovery has become the norm and the expectation now for people with severe mental illness.
So in the context of the village, and this will relate also to our discussion about the Trieste model in a few moments, in a sense, you were given a per capita budget for each person who was participating in the study.
That's right.
And you had to provide for their whole needs with that budget. Now, if you could talk a little bit about that, and then the folks in the control group, what were they attached to financially? What was the funding mechanism that was being tested there?
Grateful to you for raising this issue, Kerry, because I think, as you know from all of our discussions, the way that we pay for services has an immeasurable impact on the quality of those services and how those services get delivered and whether they're effective with people. So yes, one of the differences in our original Village program was that we were given a per capita rate for people of $18,000 per person per year. And the usual and customary, the control group, was just getting their services on a fee-for-service basis. So when they went in and they got a service, the provider got paid for it. They would bill for it and they would get paid for it. This is the usual and customary system is called Medi-Cal in California, but in the United States it's called Medicaid for people who are sort of being served in the public mental health system. And so the funding approach was fundamentally different for the Village, for all of the folks in AB 3777, because we were given a fixed amount and said, do what you need to do for these people, help them with their mental illness kind of thing. And the freedom that gives a program and the staff of the program cannot be overstated, because it allows you to do whatever it takes. That became our catchphrase, whatever it takes, with people to get them well.
What would be an example of something in the study group that you were able to provide with this all-encompassing budget that you would not have been able to provide in the control group? What would be an example? And it would be an example of something that's really rather essential.
So I'll give you the most mundane. You could use the money for somebody's first and last month's rent so you could get them out of their board and care and into an apartment. You can't use mental health money for that, but we were allowed to do that basically. And one of the things that we found is that the main obstacle for people actually getting out of a board and care and moving into their own apartment was just they didn't have the first and last month's rent to assure that the landlord that they were good for it kind of thing. Now they were able to pay their rent on a monthly basis, but they just didn't have the first and last. So there's a simple example of, oh my God, people not living in their own apartment just because they can't get the first and last month's rent kind of thing. On a more systemic basis, we used an enormous amount of our budget specifically for employment services. We hired specific staff on job developers, job coaches. We hired people who were working in our employment sites. For example, if you were to walk into the Village, you would see probably at any given time 30, 40 of the members actually working in the Village, either in maintenance or in the cafe. These were real paid jobs that were coming out of our budget kind of thing. And that would be extremely difficult for the usual and customary services to pay for. They really wouldn't be able to pay for those kinds of services. So that capitated system that allowed you to basically pay for whatever the leadership and staff deemed essential for the wellness of this person was an extremely important component of that original study.
So in terms of the evaluation, and I know it was a pretty rigorous academic evaluation of the results, describe some of the compelling findings of the Village study of the group who was lodged with you there as compared to the control group at the end of that. It was actually 3 years of
the first 3 years of the project formed the core of the study. Well, so the most striking part or result that I saw was that about 5 times as many Village members actually tried paid employment, actually went to work as the folks in the control group. And the actual numbers were approximately 73% of the Village members out of that 120 people actually were employed at some point during that 3-year period versus about 14 or 15% in the control group. And that's just an amazing difference. Is if you provide people with the opportunity to work, they can overcome the disability and go to work. work. It was also kind of humbling on one level because, we thought, just as an aside, we thought we could actually predict among our members who would be successful at work and who wouldn't. And so before we actually started this, we looked at the 120 people and we said, okay, let's divide them into 3 groups. It's like this 40, they're ready to work right now. They can go to work. This 40 middle group, they're not ready now, but someday they could be. The third group was, these people are never going to work. It's not going to happen. And the humbling part of that was that we found that there was no difference among the 3 groups statistically.
Wow.
This whole experience has been humbling in a lot of ways because it makes you question your assumptions about your ability to predict who is going to be successful and who is not. And our original village director, Martha Long, said, what we learned is that you just take people at their word. If they tell you they want to work, that's probably 80% of whether they can work or not.
Well, some of the other things I recall was the level of hospitalization was actually less in the village group. And also what I thought was interesting, that the relative burden felt by the families was less in the village group as compared to the control group. Were there a few other salient findings like that?
Yes. And the other highlight to me, people at the village reported a lot more social and recreational contact. That's that sense of belonging that I was speaking about earlier seemed to be enhanced, that they actually had those connections and they were actually being able to forge those connections out in the world. But yes, you're right about the hospitalization. We were actually able to lower the hospitalization rate, the number of days that people spent in the hospital, significantly over the control group. And family members did report less burden. They felt like that there was somebody there to help them as well as their loved one.
I've always wanted to ask you this question, and we've always been working on other topics, but what seems kind of stunning to me is that you developed this program, you had these very positive results, people's lives were being transformed, people are working, families are feeling supported, there's probably an increasing level of self-esteem and independence, the study comes to an end, and then what? Then you revert back to the customary and usual way of funding mental health services. What happened there?
So we continued on after the study was over, and the state continued to fund us. But, funding constraints being what they are, the state in 1996 said, okay, you've had a very successful study here, but it's time for us to let you go back into the county system from whence you came, kind of thing. And actually that would have been okay, except for the fact that the funding mechanism that we had that allowed us and enabled us to get all these positive results went away at that time. As you mentioned, we had to then adopt the usual and customary fee-for-service billing at that point. And we tried to convince the County of Los Angeles at that time to test us with a modified capitation rate, but we could never really get that into place. And so starting in July 1st of 1996, we joined everybody else in terms of going back to the fee-for-service billing. And again, you don't realize, because your culture is your culture, you think, oh, we'll be able to overcome that. We'll be able to manage that. And don't misunderstand me. I think we did a pretty good job trying to maintain our culture and maintain our whatever it takes attitude going forward from that point. But I can't overstate how debilitating it was that staff, especially the staff who had been with us from the beginning, said, I can't do what I used to do because we won't get paid for it if we do. And look, billing systems are set up with the best of intentions. They are set up to try to ensure accountability, but you can have accountability in a system that doesn't require a fee-for-service billing that kills the souls of your staff. I am convinced of that, but convincing the bureaucracies that be is the next step of this journey, I'm convinced. But again, I'm probably getting ahead of the story there.
I feel like we have to do like a 2-decade fast forward, because I know you had a great career at the Village, and it was only just a few years ago that you resigned. But of course, feel like, wow, just hearing what you're describing between the clubhouse and between the Village, this is what we saw in Italy, some of these basic guiding principles. And to me, it underscores how very human these instincts are to kind of care for people and to care for their sense of purpose and meaning and social connection. So let's fast forward a bit. I want to come to 2018, which is when I first met you. And of course, we're not going to go into the story today about how me as a layperson ended up in a place in Italy, Trieste, where I saw in action a remarkable system that was so human focused, and was on my own study journey to understand why it was people with severe mental illness were left to fend for themselves on the streets of America. And I was just learning about everything you're talking about right now was completely foreign to me, how the system is paid for and why the system is so complicated. So as you know, LA County had entered into a collaborating agreement with the Trieste mental health system to consider a pilot in Los Angeles that could be funded by the state. We'll talk about that funding source in a moment. And it would be predicated upon many of these similar guiding principles that you saw work so well in the 90s. So I remember there was a day we had 5 visitors from Trieste, Italy, who had come to Los Angeles in September 2018. 3 were psychiatrists, 1 was a psychiatric nurse, and 1 was a lawyer. And we took them on a whirlwind tour of the LA County mental health system, which was like the most shameful week of my life. We went to the jail, and we went to Skid Row, and we went to locked IMDs and the psychiatric locked wing of the hospital, all the things that they don't have in Italy. And at the end of that week, Dr. Sharon, who is the head of the LA County Department of Mental Health and is pretty new in his job, I think it just started within the year as a change agent is what the Board of Supervisors was looking for. He said, I know exactly the person I need to call to draft a proposal that we could present to the state to see if we could get funding to do a pilot in Los Angeles. I had no idea who he was going to call. He goes, I hope he takes my call. So I want to know what happened on that phone call, because it was you that he was thinking about.
Dr. Sharon called me up and said, there's this great group of people who have been to Trieste, and they're really wanting to put together a proposal to bring some of these principles over from Trieste into the Hollywood area. And Dr. Sharon had talked to some other people and had gotten my name, and several people had recommended me. And I said to him, John, if you're going to do this, I'm all on board, but only under one condition. We have to blow up the funding mechanism for this system. And to his credit, Dr. Sharon said, we're blowing up the system kind of thing. And so I said, you had me at blow up. It's like, that's the story, basically. I said, I can write this proposal, but if it doesn't address the fundamental issues around the bureaucracy and the way we fund mental health systems, it's going to go nowhere. But he was completely on board with that idea. That's when I came on board. I'd only been retired for less than a year at that point and was enjoying retirement, by the way. It's like, I'm not sure that I should have. It was wonderful to have one's expertise and experience recognized and valued. And I feel so grateful for having had the opportunity to bring all that expertise and to go through that process for the next approximately, 8-9 months as we put the proposal together.
Yeah. And that was right around the time I met you. I remember we met at that restaurant at Gardena, which is where we would go today if we could, which we will go to when we can. Yep. So we ended up going to Trieste in December of that year because it really, I always say, you can read about the Trieste system, which is, as we know, recognized by the World Health Organization as a global best practice in community-based mental health care. You can read about it, you can talk to people about it, but you have to actually kind of like be there and insert yourself into the system and see the culture and see how the users, they call them the users, interact with the staff and how horizontal those relationships are. And I don't want to put words in your mouth. You and I went back there with Dr. Sharon in December of 2018 so that you could have a bird's eye view and also talk to the team. What do you remember about that trip? And also, I'm thinking now it must have been so validating Absolutely. On what many of your instincts were going back to the early 90s.
It was instant kinship, Kerry. These people are family. They believe in and value the same things that I've been promulgating for my entire career. They might not talk about it in exactly the same way, but at its base, at its foundation, they are talking about helping people to find meaning and belonging in their lives, and that people are not defined solely by their mental illness. And you can see that from all of their social collectives and the way that they provide employment opportunities for the people that they serve. Exactly what I described that we were trying to do as well in Long Beach. So there was an instant feeling of connectedness and kinship there with that program. And it wasn't surprising to me, by the way.
It wasn't surprising. No, it's human.
Yes.
It's just It's
exactly.
Just really human. Is there anything about that week? I don't even think it was a full week. Maybe those 5 days. Is there any particular story or experience about that week that particularly impacted you or moved you?
So I'll just mention two things. The first thing is specifically, I was so impressed with the level of integration of their programs with the community. The Trieste community has embraced their mental health system in a way that I actually believe that NIMBYism is one of the biggest problems that we have in this country when it comes to serving people with mental illness. And the level of not only acceptance, but almost positive love that the community gives the mental health program there. I mean, you talk to people on the street and they have positive attitudes towards people. So that was the biggest thing. It's like they have done a remarkable job of expanding the mental health system out so that it is just part of the community. And the other thing I'll mention is, not to embarrass you, but getting to know you in that 5 days, I've been so impressed by your commitment. And as a layperson, I don't often meet people who have the level of commitment. And it was a great gift to me to be able to get to know you and to see because you represent that community spirit and that integration of that this is everybody's business. It's not just the professional's business. It's about how we help the community to serve the people with severe mental illness. So sorry if I embarrassed you, but there you have it.
Thank you. I mean, and that's part of the reason why I'm doing this podcast, because I want to make these topics accessible to the layperson. I've learned a lot about, as you described, why things are so complicated in America. But ultimately, if we can just go back to the roots of how we should be treating, our fellow brothers and sisters, that's on us as community members to push for that. So we come back. Now we're into early 2019, and tell us about this group that Dr. Sharon had identified as a potential funder for this project. And I know that part of the requirement is that you have to present true innovation. And this is what you were tasked to do, is to put this innovations proposal together. So we're going to attach this on our website for the podcast so people can read it, but give us the bird's eye view of that proposal.
Sure. When the voters of California passed the Mental Health Services Act back in 2004, it created this thing called the Mental Health Services Oversight and Accountability Commission, which decides on the funding for mental health programs. And they decided on a category called innovation funding because they wanted to encourage new ways of looking at programs. And so LA County decided that this proposal would make a wonderful innovation project. And so when they asked me to write the proposal, I went out and started collecting all the information from the stakeholders, the people who were impacted by this. We held many, many community meetings in Hollywood and elsewhere, gathering information, plus all the experience that I've had with funding and the billing systems and all of that. And we decided to submit this proposal under the innovation grants. And we came up with a 5-year proposal to the MHASOC, Mental Health Services Oversight.
Oversight and Accountability. Yeah, it's a mouthful.
The proposal was submitted, I think it was May 23rd.
May 23rd, 2019. Right.
Exactly. And we did a presentation. The commission actually came down to Los Angeles and heard our proposal, along with a proposal from Orange County. And I forget, there was another county, maybe Riverside County, I can't remember, was also presenting a proposal that day. They decided that they really liked what we had written and decided to fund us to the full amount that we requested, $116 million over a 4-year period. And the first year of that was intended to be a planning and input year kind of thing. And services wouldn't start until the 2nd through the 5th year. But yeah, it was quite an accomplishment, I think, to get this source of money to actually try out these new ideas.
Yeah. And I think, Dave, to your credit, your proposal, it is 57 pages. And like I said, we will link to it on the website. What I learned from that as a layperson, that, several of the innovations that you had built into this, and as I never understood any of this until, I came alongside you and understood what you were trying to propose. You were in a sense suggesting that we uncouple services from our traditional Medi-Cal fee-for-service clinical model to a per capita budget for this catchment area in Hollywood, so that people could be met where they're at and that their whole person needs could be addressed, and there'd be minimized documentation and record keeping for the staff doing that work. That is so profoundly simple, but that is the innovation.
Absolutely. That is the innovation, Kerry. It's for 30 years or so, we've known what works for people. I have to say that I have rarely, if ever, met a staff who didn't have their heart in the right place. They want to do what's best for the people that they serve. But I've watched as they felt more and more hamstrung in those efforts, because it feels like whenever they turn around, somebody's either asking them for documentation or questioning their billing or those kinds of things. And so if we're going to be successful, we have to come up with a new system of accountability that minimizes those kinds of burdens on staff. I have to state again, I am not against accountability. I am all about accountability, but it can't come at the cost of the quality of the services that we provide. And I think that that's been the fundamental issue in our mental health system.
So, of course, for the folks who are listening to this, so the state authorized this funding. That was the beginning of a process where the county then had to put in place a framework to actually accept the money and to begin to be able to proceed with the planning year that Dave just mentioned, because there are a lot of moving parts that had to be taken into consideration to launch the pilot. And so the county was making progress in that direction. It's a big lift. It's a big amount of money, and there's a lot of system and culture change inherent. And then this thing called the pandemic, on the scene earlier this year, right as things were picking up speed. So I'm just a believer that there's a reason for everything, and we're taking a pause on the pilot. I'm using this opportunity to keep telling this remarkable story, a remarkable story that already exists. What the village accomplished, it exists in what clubhouses do. And we're actually going to explore the clubhouse model during this first season of Heartforward podcast as well. And it certainly exists in Italy, been recognized by the World Health Organization. So we're onto something. It's just that how do we untangle the mess that we're in that keeps this from happening? So I have one last question for you, Dave. You've been so generous with your time. I've been on this journey since 2017. As a layperson, just trying to make sense of why is it so hard to help people with mental illness? Why are they in our jails? Why are they on our streets? And I have a better sense of that now. And people will say to me sometimes, well, why did you have to go all the way to Italy to see something better? Like, what could we possibly learn from the Italians? And I think, well, if it was Greenland, maybe people wouldn't have that concern, but there's something about Italy. But, and trust me, it is not easy to get to Trieste. It is like a 30-hour planes, trains, and automobiles to get there. It is not an easy city to get to. But what would your answer be to that, Dave? What can we learn from the Italian model, and why is it worth not ignoring?
What has happened in isolated places throughout the world? Your experience in Trieste is pretty unique for you. But I've actually seen those services in other places, kind of thing. It takes leadership, I think, to create systems that empower our fundamental caring for our fellow human beings. And it's not that people don't want to do this, but we feel hamstrung by the bureaucracies that we put in place to try to safeguard the money that is in the public interest. But I think that all we have to do is remember that these folks are, but for the grace of God, go I kind of thing. And programs that embrace that idea are going to be much more successful because they can actually see the humanity in those folks. But it's a hard sell to a community when, they feel like, oh, they're causing disease or they're causing trash or, it's like, why can't you clean up this homeless problem or something like this? I think you've experienced that in Hollywood to a large extent. But it takes leadership in the community, such as you have provided, to help people to see that these folks are our neighbors and that they can actually live productive, meaningful, wonderful lives if we, provide the resources and the help for them to do that. So I've been through these change processes many times. And the reason why I still feel positive about Hollywood, even in the face of the pandemic, is that the Hollywood community has embraced this project. Under your leadership, I think that people say there's a better way to go, and we have a vision of that, and you have helped provide them with that vision. And I know that Trieste means so much to you. And believe me, it's a wonderful program, but it embodies something that's bigger than itself, bigger than Trieste. And without your leadership and without the leadership of other people in Hollywood, it wouldn't happen. So give yourself some credit for that. Yes, you found this model in Trieste, but without the participation of people like yourself in Hollywood, nothing like this would have happened.
Well, thanks, Dave. I mean, we've been a good team, me with a sense of passion and the community sensitivity, and you with all the technical knowledge and the great experience that you had in Long Beach, and everything's just seemed to come full circle with how our lives intersected and the fact that we are not going to give up hope that there is something really profoundly important in what we're learning. And I have this thing in here somewhere, never, never, never give up. And I think it's paraphrased by Winston Churchill. So we promise that to each other, right, Dave?
Absolutely. Words to live by.
Okay. It's so great to have you today. I owe you a lunch when it's safe to do so.
Absolutely.
And thank you. We'll sign off for now. Thank you, Dave.
Good to see you, Kerry. Thank you.
Dave summarized what we witnessed in Trieste so well when he describes a city that helps their neighbors living with a mental illness find meaning and purpose in their lives. They are not defined by their mental illness. They are supported in their life plans and aspirations. That is why Trieste is called the city that cares. Next week, you will have the rare opportunity to take a glimpse into the Los Angeles County Jail, where you will meet two inmates who have co-authored a book about their role as mental health assistants. The two men have lived 24/7 for the past 3 years with acutely mentally ill patients who live in a specialized dorm setting. The goal is to prevent isolation and decompensation. I am so grateful that the leadership at the Sheriff's Department and the jail granted me permission to talk with these two very committed men, Adrian Baruman and Cragen Armstrong, and you won't want to miss this. I thank you today for being here with me, and I hope that you will subscribe to this podcast and share with others. I could not do this without my collaborating partners at Peer Mental Health here in Los Angeles. And most specifically, I am grateful to the support of Paul Robinson, who provides the technical support to make this podcast possible. I will see you next week.